Hello, welcome. It's my great pleasure as Acting Chief Medical Officer at the Australian Commission on Safety and Quality in Healthcare to welcome you to the launch of the 4th Australian Atlas of Healthcare Variation. I'd like to start by acknowledging the traditional owners and custodians of the land on which we meet and pay my respects to elders past, present and emerging. Now, COVID has taught us how to do online conferencing, but if you do have any problems during this launch, make sure you ring 1800 733 416 so you don't miss any of this launch. As I said, this is the 4th Atlas of Healthcare Variation, and each Atlas, we have learned a great deal. Each Atlas has provided deep insights in how the use of healthcare differs across Australia. And it depends on where people live. We've seen marked variation at times, and when we see variation, we know that that can be a marker of a sophisticated healthcare system that is responsive to differences in patients' needs or preference. However, we can also see variation which is reflecting of a much more serious issue, and that is that some people are receiving care that they don't need and are being exposed to harm without benefit. Or on the flip side, in areas where we see low rates, that there may be people missing out on care that they do need. In this atlas, we're looking at a number of areas of great importance, but I want to draw your attention for a moment to the chapter on early birth. It illustrates how important it is that we ensure that the evidence that we learn is implemented. And when we look at planned birth, we see a significant proportion of babies born before 39 weeks as a planned activity without obstetric or medical indication. So we're seeing a drift away from the evidence, and we'll hear from Professor Newman, who will actually tell us more about this important issue. We also looked at potentially preventable hospitalisations. Again, we saw marked variation, an 18-fold variation, for example, in hospitalisations for chronic obstructive lung disease. And yet we know there's good evidence that enables people to manage that chronic disease in the community without having frequently to go to hospital. So it does raise the issue of whether the evidence is getting into rural and remote areas where we see the highest rates in this atlas. There are a number of other areas which we've looked at in this atlas, but that's for after the launch. It is now time for me to introduce our first speaker. I'm pleased to introduce to you the Honourable Greg Hunt, Minister for Health and Aged Care.
I'm delighted to launch the Australian Commission on Safety and Quality in Healthcare's 4th Atlas of Australian Healthcare Variation. To Deb Picone, to Professor Villis Marshall, to everybody associated, whether it's through the Commission or through the AIHW, you've done fantastic work in the service of the nation. The Atlas gives us a snapshot of how Australians are using healthcare across a range of different demographics, whether it's by geography, whether it's by age, whether it's by gender, whether it's by other variants. We can learn about the way in which different services are used. Now, there are natural variations, completely appropriate, utterly appropriate. But then from time to time, we will see areas of disadvantage or over-servicing. One example, of course, was an earlier iteration of the Atlas, which identified the challenge and the problem of knee arthroscopies for over 55s being arguably used on a more frequent basis than was clinically optimal. That led to the review by the MBS task force, which led to the change. Clear case study of an important change to help the health of Australians. And then we can understand, of course, where there are differences which show underutilisation, a lack of access for certain people. And that's a very important societal insight. So it's not just clinical, it can be societal as well. And that brings me to this atlas, the 4th Atlas of Australian healthcare variation. We know some of the key findings include the very significant work which shows that when you look at the preterm birth, that where caesareans are being booked in at under 39 weeks, and we have outcomes which may not be always optimal. There's increasing work being done, led by a former Australian of the Year, Senior Australian of the Year, Professor Newnham, which looks at how we can take these interventions to prevent preterm birth. Equally, that can transform practice, and combined with the hard data here, we can improve developmental outcomes and improve safety outcomes for the littlest of Australians. I can't think of a more important work. At the same time, there are preventable conditions, and the Atlas identifies at least 330,000 preventable treatments for conditions where early intervention can prevent those conditions leading to hospitalisation across 5 major areas. That gives clinical and policy leaders evidence to take steps to improve lives, to save lives, to protect lives. And that's a pretty good outcome. So with that, I want to thank everybody involved in the preparation of the Atlas, and I am delighted to officially launch the 4th Australian Healthcare Variation Atlas.
Thank you, Minister Hunt, for launching this Atlas. As Minister Hunt noted, the findings from this Atlas have far-reaching societal implications. And to talk about this, I'm very pleased to introduce Professor John Newnham, AM. Professor Newnham was the 2020 Senior Australian of the Year. He's a Professor of Obstetrics at the University of Western Australia. He's Head of Department at the King Edward Memorial Hospital, and he is the Chief Scientific Director of the Women and Infants Research Foundation. Professor.
Hello. Firstly, I would like to thank Professor Anne Duggan for the generous introduction and to express my gratitude for being given the opportunity to give this talk. I'm speaking today on behalf of the Australian Commission on Safety and Quality in Healthcare at the time of release of the 4th Atlas. This Atlas is dealing with prevention of preterm birth and in particular early term birth, which I will discuss in detail soon. Preterm birth is the single greatest cause of death in young children in Australia and one of the major causes of lifelong disability, including issues such as cerebral palsy, blindness and deafness. And being born at the later preterm ages and early term ages may be followed by increased chances of behavioural and learning problems at school age. The title of this talk is Safely Preventing Harm from Unnecessary Preterm and Early Term Birth, delivered to you on behalf of the Commission, but also in collaboration with the Australian Preterm Birth Prevention Alliance, which is a subcommittee of the Perinatal Society of Australia and New Zealand. The social media campaign that underpins our national program is known as the Whole 9 Months, and I'm employed by the University of Western Australia. Australia's preterm birth rate has been rising dramatically, as it has been across all developed countries like Australia in recent years. From the mid-1990s, the rate has gone from just under 7% to well over 8% today. This is important because this condition of preterm birth, as I said previously, is the single greatest cause of death in young children and a major cause of disability in our community. It is also very, very expensive. The Australian Preterm Birth Prevention Alliance grew out of an initiative started in Western Australia in mid to late 2014. As a result of the early success of that initiative, we were funded by the National Health and Medical Research Council in Canberra through a partnership grant to roll out the program across Australia, and thus was born the National Alliance in June 2018. This is the world's first national preterm birth prevention program. Australia is the first country in the world, and at this stage the only country in the world, to have such a national program. That the social media campaign and all the print media campaign you will recognise by the name The Whole 9 Months. So this is a slide showing what happened in Western Australia when we introduced a suite of interventions. Now there were 7 interventions, which you can find in any of the references provided in the atlas, but essentially they came down to education of the healthcare workforce and the women and families of our state that no baby should be delivered before 39 weeks gestation without a medical or obstetric indication. Secondly, we made sure that the length of the cervix was measured at all mid-pregnancy scans conducted in the state at the time when all Australian women will have a mid-pregnancy scan. If the cervix is short, it predicts early birth. If the cervix is long, it predicts term birth. And if the cervix is found to be short in mid-pregnancy, there's something we can do about it. Prescription of a simple tablet called natural vaginal progesterone, taken each evening till 36 weeks gestation, has a dramatic effect in reducing the risk of preterm birth. We also introduced use of that treatment for any woman with a past history of preterm birth, which is a very strong predictor of future outcomes. This slide is a run chart. This is implementation research, and implementation research is presented as run charts. On the vertical axis is the thing we're interested in, which in this case is singleton preterm birth. The red dotted line represents the median of the preceding years. In other words, what the rate has been doing over preceding years. The horizontal axis shows the time. Here, pale blue represents when the initiative had been introduced. The dots on the graph represent epochs of time, predetermined epochs of time. And if you have 6 below or above the median in a row, that denotes statistical significance. This slide shows the effects of introduction of the initiative in our major hospital, our major perinatal hospital in Western Australia, King Edward Memorial Hospital. And as you can see, there was a dramatic and immediate reduction in preterm birth by about 20%, highly statistically significant, and the effect was sustained. This slide shows the effect across the state overall. Now in the state overall, there was a reduction in preterm birth after we introduced the initiative and after we did an outreach program making sure that everybody in the state understood what we were doing. But the effect then dissipated. We took our foot off the accelerator, the effect went, and in fact the rate started rising in parallel with the rest of Australia. This taught us that we can, with known knowledge today, safely lower the rate of preterm birth, but the program needs to be sustained and continued or it will lose its effect. After all, it's heavily based on education, and the population we're educating is turning over every 9 months because they're pregnant women. But thus was born the Australian Preterm Birth Prevention Alliance, which has a single goal, and that is to safely lower the rate of preterm birth across our nation. This slide represents the names of the 28 people on the steering committee representing all of the 6 states and 2 territories in Australia, the people who are taking the lead role and all the various disciplines that need to be represented for us to be effective in safely implementing this program across Australia. And this represents the smiling faces of these 28 people at a meeting in Sydney pre-COVID in November 2018. In the front row you will see the executive, and these faces are the faces that are leading our national initiative right today. This slide comes from Australia's Mothers and Babies reports 2007 and 2017, showing the effect of time on our preterm birth rate and our early term birth rate. Now, preterm birth is defined historically as birth before 37 completed weeks of pregnancy. This is an old definition we have inherited from our ancestors. It comes from more than half a century ago, when data collection and understanding was, of course, less. We now know a baby at 37 weeks is not fully mature. The answer should be 39 weeks gestation. It takes till 39 weeks for the baby's brain and other organs to be fully mature. Between 35 and 39 weeks, the baby's brain puts on another half in its weight. Now, if it is delivered early, some of that can be recovered after birth with brain development, but clearly much of it cannot. So the definition should be 39 weeks, but we're not changing it because it is entrenched at 37 weeks. We now call birth before 37 weeks preterm birth, and birth at 37 and 38 weeks as early term birth. This slide shows on the left the rate of preterm birth before 37 completed weeks, showing the increase as I had shown previously. But the next two sets of bars show the rise in early term birth at 37 and 38 weeks. You can see that across Australia, like all developed countries of this type, the rate of early term birth has been rising, and there are serious implications from that happening. The 4th Australian Atlas of Healthcare Variation also shows the rates of planned birth before 39 completed weeks. This slide shows in 2017 caesarean section rates with no medical or obstetric indication. Before 37 weeks, the rate rose from 13 to 19%, before 38 weeks from 25 to 33%, and before 39 weeks from 43 to 56%. That means a very high proportion of planned deliveries before 39 weeks gestation by caesarean section have no obstetric or medical indication. So the question is, what does that mean? Here's a hypothetical scenario. Concentrate heavily on the next few slides and you will understand it. So, early term birth, the clinical question. Here's the scenario. You are the obstetrician. You are with your patient. In partnership, you are making a decision to deliver the baby today at 37 weeks gestation, or to wait 2 weeks and deliver the baby at 39 weeks gestation. This scenario, of course, assumes there is no compelling reason why this baby would need to be delivered. So, to deliver today at 37, or to wait 2 weeks and to deliver at 39. Now imagine you are the only obstetrician feeding the school down the road. The school down the road has 500 children in it, and this scenario shows what the school will look like 8 years from now. So you're the only obstetrician producing babies for this school, and every person in this school has come from the one obstetrician. What does that school look like 8 years later? So here's the school of 500 children, and from the next few slides show what the school will look like if you had delivered all babies at 37 weeks as opposed to all babies 2 weeks later at 39 weeks. Well, the first is you will prevent a stillbirth occasionally. So if you deliver babies early, by necessity and by definition, you will save a stillbirth. How many do you have to deliver to prevent a stillbirth? Well, the Atlas has estimated you have to deliver 2,000 at 37 weeks to prevent a stillbirth. Using West Australian data, the answer is 1,300. For the sake of this slide, we're saying that it's 1,000. In other words, for this school of 500 children, 8 years later, there's a 1 in 2 chance of an extra child in that school. Now, of course, this implies that the obstetrician has no clinical judgment, which is not the case with Australian obstetricians. So if something were to emerge as a complication or a risk factor, the obstetrician may elect to deliver the baby early for an obstetric or medical reason, or to start fetal monitoring and fetal assessment to assure it is safe. But for the sake of this scenario, we assume the obstetrician is not making such a judgment. So there's a 1 in 2 chance you'll have an extra child, but at what price? Each class of 30 children will have 2 children with an externalising behavioural disorder. They are behavioural disorders where the child has difficulty concentrating and behaving well. Across every 2 classes will be 1 child with a need for a special educational assistance. And across every 3 classes, there will be 2 children with a basic numeracy problem. And if you don't understand that sentence, it might mean you've got a basic numeracy problem. Regardless, here's the school 8 years later. So if we deliver all babies at 37 weeks as opposed to 39 weeks, eventually we may prevent a stillbirth, though that number would be reduced enormously by good clinical judgment. But we will have major educational and behavioural issues in that school, with increased rates of behavioural disorders, need for special education, and children with numeracy problems. Now, of course, this is population-based data. So within an individual case, your child, this may not apply. And of course, extra attention after birth and extra education after birth can ameliorate some of these effects. So then, that is the situation with birth at 37 or 38 weeks gestation. Can we in Australia safely lower the rate of early term birth? Do we have the tools to do it? And the answer is we do. The Australian Preterm Birth Prevention Alliance, rolled out across Australia's 8 jurisdictions, and is now producing results. So in the Australian Capital Territory, published just recently, was the result of the whole 9 months ACT program. And after the first 1.5 years, they had lowered their preterm birth rate by 10%, but they'd lowered their early term birth rate by 34%, and they had done it safely. So, using known knowledge and with intensive implementation by people very committed to the task, we know we can lower the rate of early term birth. But it takes a lot of work, it takes a lot of commitment, and to sustain it is going to take a lot of investment. And that is what the fourth Atlas is all about. It is taking a leadership role in turning around this increase in early term birth rate across Australia. The recommendations you will find in the fourth Atlas come under these categories. Firstly, prevention of preterm and early term birth now needs to become a national priority. Implementing new clinical guidelines and education is effective, but ongoing success and further improvements now require policy change. The national debate needs to begin and can include discussion on targeted audits, development of indicators, and perhaps changes to payments from this Medicare benefits schedule. You will find details of these recommendations in the fourth Atlas now being released, and I commend it to you. Over the last 2 decades, we have come to learn that life before birth is of critical importance for our future health, for our future propensity for illness, for our future behaviour, and for our future potential for happiness and success. And of all those things that we can do in Australia to improve the outcome of people at the time they are born, it is to prevent preterm and early term birth, so that every Australian is born with the best possible chance of a good life. Prevention of preterm birth and early term birth is now becoming a national priority. The Commission is showing great leadership in this regard, and I commend the recommendations to you. Thank you for your attention.
Thank you, Professor Newnham, for such a powerful presentation and persuasive arguments that demonstrate we must do something for the betterment of future generations. It is indeed a call to action. I'd like now to introduce Professor Paul Kelly, Chief Medical Officer of the Commonwealth Department of Health. Professor Kelly is a public health physician and epidemiologist of over 30 years research experience. He's worked around the world in health system development and infectious disease epidemiology. Professor Kelly.
Thank you for the invitation to help launch the publication of the 4th Australian Atlas of Healthcare Variation. I would like to thank the Australian Commission on Safety and Quality in Healthcare and the Australian Institute for Health and Welfare for their development of this comprehensive report. Thank you also to the Safety and Quality Commission for your ongoing work to improve the safety and quality of healthcare for all Australians. The goal of the Atlas series of publications is to ensure that all Australians receive the best possible healthcare. The Atlas series provide a unique dataset and evidence to examine the Australian health system by exploring how healthcare use in Australia varies depending on where people live. This is the 4th Atlas the Commission has produced, and taken together, the series provides great insight into healthcare delivery in Australia. The 4th Atlas investigates reasons for variation that may be unwarranted and provides recommended actions to reduce unwarranted variation. Variation in healthcare delivery can be a good thing if it reflects health services that are responding to differences in patient preferences or underlying needs. However, when a difference in the use of healthcare services does not reflect these factors, it may represent an opportunity for the health system to improve. In this edition of the Atlas, the Commission examined 17 investigations and treatments provided in acute and primary care settings across 6 clinical themes. In each area, key findings and recommendations for improvement are outlined. It is important that all governments and healthcare providers take the time to consider the findings and recommendations contained in this publication. The Department of Health will carefully consider the report and all findings and recommendations in the coming months. For example, the Atlas has pointed to the need for change in preventable hospitalisation rates for people with chronic diseases. The Atlas reports that more than 330,000 potentially preventable hospitalisations in 2017-18 were due to 5 key chronic conditions, and trends show that these numbers are rising. These 5 conditions include chronic obstructive pulmonary disease, COPD, kidney infections and urinary tract infections, heart failure, cellulitis, and diabetes complications. The Atlas also reports the growing evidence that early planned birth of babies before 39 weeks, where there is not a medical or obstetric reason to do so, increases short and longer term risks for children. In response, the Atlas proposes changes to hospital policies and other aspects of our health system to encourage planned caesarean sections to happen after 39 weeks where it is safe to do so. By stimulating review of healthcare use and promoting appropriate care, the Atlas guides better use of our healthcare resources and better outcomes for patients. In the 4th Atlas, case studies reporting on action prompted by previous Atlas publications are included. For example, one case study discusses how the first Atlas showed that a particular area of Australia had higher than expected use of anxiety and depression medicines. The use levels were not justified by differences in the rates of anxiety and depression in the population. In response to these findings, further analysis of the Atlas findings were undertaken by the local health service, followed by a number of actions to improve the quality of clinical care. Thank you again for inviting me to be part of the launch of the 4th Atlas of Variation of Healthcare. As a healthcare professional and epidemiologist, I commend the work of the Safety and Quality Commission and the AIHW on this important publication. The 4th Atlas is a key resource to help the Safety and Quality Commission and all Australian governments to identify areas of concern and to work together to improve health outcomes. The Australian Government will consider all findings and recommendations, and I urge others to do the same. Thank you.
Thank you, Professor Kelly, for commending the Atlas as a key resource. I'd also like to take this opportunity to thank the Commonwealth Department for Health for their support in developing the Atlas. As I mentioned earlier, the Atlas examines many other areas. So I just want to take a few minutes to think about one area which I think is very important, and that's ENT surgery in children and young adults. We looked at tonsillectomy, which is one of the most common procedures performed in children in Australia. And we found a 6-fold variation. Now, we know that tonsillectomy used to be performed for tonsillitis, but in many countries of the world, we're seeing a decline in tonsillectomy for tonsillitis. But we're also seeing a rise in tonsillectomy for obstructive sleep apnea, despite the uncertainties in the evidence. A 6-fold variation does raise the question, are some children receiving unnecessary surgery? In contrast, when we looked at myringotomy, we also found a variation, but that raised other issues. Myringotomy is a surgical procedure on the ear for children with chronic ear infections. It's often associated with a grommet, a little ventilation tube to help drainage of the ear. And we know that children who suffer from chronic ear infections are at risk of permanent hearing loss if they don't have it treated. Aboriginal and Torres Strait Islanders are much more likely as children to get middle ear infections. So it is incredibly important that these children who have got mental infections have the surgery at the right time. Without surgery, hearing impairment can be permanent, learning can be affected, and it may alter someone's life course. Fortunately, in the Atlas, we did see a rise from that last time we looked at it, but still, we really do need to ask the question, are children who need neurogotry still missing out? I'll leave you to look at that chapter after the launch. I want to now introduce Professor Villis Marshall, AC. He's the chair of the Commission's board. Professor Marshall has a considerable experience in providing healthcare services, managing hospitals, and improving safety and quality. He has also significant clinical experience as a urologist, as the clinical director for the Royal Adelaide Hospital, and as clinical professor of surgery at the University of Adelaide. Professor Marshall.
I would like to close today's launch by acknowledging the Commission's partnership with the Australian Institute of Health and Welfare in producing the Atlas. I would particularly like to thank the Health Minister, the Honourable Greg Hunt, for launching the Atlas and for his insights about the important role of the Atlas in continually improving the health system. Many individuals and organisations have provided invaluable feedback throughout the development of the Atlas. Thank you to our colleagues from state and territory health departments, clinical colleges and societies, and consumer representative organisations. Thank you also to all the clinicians who have played a critical role in analysing and interpreting the data. I want to pay tribute to the staff of the Commission for producing an outstanding Atlas with such powerful findings. The data in the Atlas series helps us to see patterns that we often cannot see from our individual perspectives and alerts us to problem areas. Given the considerable demands the COVID-19 response has placed on the healthcare system, my vision is for the findings in the Atlas to be used to direct resources to those with genuine clinical need and to identify and minimise low-value care. I urge you to use the wealth of information in this Atlas to improve healthcare delivery.
Thank you, Professor Marshall, for reinforcing the importance of acting on the findings from the Atlas. I'd like to take this opportunity to thank a number of people that made this Atlas possible. Our partners, the Australian Institute of Health and Welfare, who helped provide the data and worked with us throughout this time. I'd also like to thank the hundreds of clinicians and policymakers who looked at the data, interpreted, gave us insights that we didn't see, who helped us develop the recommendations which we believe will reduce unwarranted variation. I'd particularly like to thank the Atlas Advisory Group and, of course, the staff of the Commission for producing such an important resource. And, of course, without the leadership of our Chief Executive, Professor Deborah Piccone, it wouldn't have been possible. But most of all, I'd also like to thank the speakers today and you, the audience, have taken the time to come to this launch. The findings of this Atlas compel us to act. The Commission has made a series of recommendations for action, and it is now time to act. We need to ensure that we are partnering with consumers, giving them the information they need, the evidence-based information to make wise choices and be partners in their care. We need to ensure that health services take a systematic approach to modifying the way they provide care so that it is in line with the evidence and supporting both clinicians and consumers to have the best outcomes. And of course, we need to ensure that all clinicians understand variation, know the results of their practice, and are working to ensure appropriate care. There's a wealth of information in the Atlas. I invite you now to explore the interactive Atlas, to look at your area and to see where the opportunities are, so that we can all work together to provide the most appropriate care for all Australians. Thank you.